Hi everyone, my name is George Mina and I'm Emergency Medicine Research Associate at the University of California, Irvine, and today I'm presenting on the incidence of detecting a culprit occlusion on patients with percutaneous coronary intervention activation having regional wall motion abnormalities on emergency point of care cardiac ultrasound. For short, we're going to call the study STEMI ultrasound study. Background: about 1/4 of the deaths in the US are attributed to heart attacks. Diagnosis of a heart attack includes a combination of factors, such as the history of the patient, which is the genetic aspect, physical exam, blood tests, which are the biochemical aspect, echocardiogram, ECG, which is the electrical aspect, and an angiography. A heart attack is a time-sensitive condition, and that's why the patient needs to be treated right away. And as you can see on the right, the ECG usually detects the myocardial infarction, and we have 3 leads, and the 3 leads and different locations on the leads tell the physician the location of the possible location of the myocardial infarction. And in our case, we're examining ST segment elevation myocardial infarction, known as STEMI, and its location. And after that, angiography is then used to visualize the myocardial infarction, followed by an angioplasty to remove the myocardial infarction in the cath lab. The rationale of the study: ECG usually detects the electrical evidence of a myocardial infarction, which is subject to false positives like any other tests. Point of care ultrasound or POCUS is used to be another added measure to detect evidence of focal heart ischemia and or dysfunction. POCUS can detect a regional wall motion abnormality within seconds of the culprit occlusion. On the right, we have 4 of the main coronary arteries, and today we're going to be focusing on the right coronary artery and the left anterior descending coronary artery. The goal of the study: the purpose of the study is to determine if peristernal short-axis cardiac POCUS can detect regional wall motion abnormality on patients presenting to the ER with chest pains meeting the STEMI activation criteria. We will evaluate if there is an association between patients who have a regional wall motion detected on bedside POCUS and their incidence of finding an occlusion on the coronary angiography. And on the right, this is an example of a peristernal short-axis cardiac POCUS. As you can see on the right, where there's an empty hole, this is the left ventricle, and the physician's job is to detect if there is any abnormal motion in those walls of the left ventricle. So our hypothesis: we suspect that our selected patient population with regional wall motion abnormality on POCUS will have high incidence of culprit occlusion on cardiac angiography and predicting the occluded artery. The criteria for our patients: the inclusion criteria is patients over 18 years of age, STEMI activation patients, patients that have gotten the cath lab results and went to the cath lab. They received the cardiac ultrasound during a STEMI activation. Exclusion: no cardiac ultrasound under 18, psych and incarcerated patients, a history of cardiac arrest or any cardiac abnormalities in the past. The methodology: so the research associate, or the MRAPper, screens for patients with chest pain and STEMI activation, then lets the physician know, and the physician conducts the short axis cardiac POCUS. Then the ED physician predicts the site of the occlusion based on the ultrasound by filling out a data collection sheet. Then the comparison between the ultrasound findings to the cath lab final diagnosis is made. The results: 19 patients were enrolled, and on 95% confidence interval, the sensitivity of the left anterior descending coronary artery was 36.4% and the specificity was 33.3%. On the other hand, the right coronary artery had a sensitivity of 60%, specificity of 75%, which is low by any standards. But the good news is that sensitivity and specificity of detecting a STEMI was 100%. So discussion and limitations of the study: cardiac POCUS allows for another added approach that can speed up the process of a patient going to the cath lab to receive treatment. With cardiac focus added as another measure, sensitivity and specificity to detecting a STEMI can be improved, which basically lowers the false positive rate. What needs to be worked on in the future is the sample size to increase the reliability of the results. And we also need to standardize the ER physician training in administering short axis cardiac focus. Also, detecting the arterial location of myocardial infarction on focus was low in accuracy and raises the question of, is it clinically relevant for ER physicians to be detecting the location of the myocardial infarction, or is it enough for them to detect STEMI activation based on focus? Future directions and conclusion. In the future, we would like to conduct a study with Speckle, which is a vectorized ultrasound system that will better locate the regional wall motion abnormality on focus, and we can compare it to the standard ultrasound machine, and truly examine the relevancy of detecting the location of the myocardial infarction on focus for the ER physicians. Overall, detecting a STEMI activation based on the cardiac regional wall motion abnormality on cardiac focus was very specific and sensitive in its accuracy. Thank you.